Sympathomimetics, that is the drugs which mimic the sympathetic action, are classified based on the mechanism of their action and whether these sympathomimetics are present naturally in body and an analog or similar drug can be given from outside, or they are not naturally present in the body, so that we classify it as endogenous catecholamines and non-endogenous catecholamines. Some of them are non-catecholamines, so that we will see the classification. But to understand their action, we need to know that which receptors of this sympathetic activity they are acting on. So in sympathetic system, we have alpha and beta receptors. Alpha receptors are further classified into alpha 1 and alpha 2 receptors. And beta receptors are further classified as beta 1, beta 2 and beta 3 receptors. Now these receptors, when the drugs bind on these receptors, they bring about different actions, and also these receptors are present differentially in different organs. Okay, so for example, alpha 1 receptors are present on the prostatic urethra and they are present in the eyes. Okay, so in eyes they bring about dilation of the pupil. They are present on the dilator pupillae. Then they are present on the sphincters, that is GIT sphincters and the bladder, internal urethral sphincter. So when these receptors are stimulated, they cause a contraction of the sphincter. Simple to remember, sympathetic system causes decrease in the motility in GIT and bladder. Okay, so obviously there will be sphincteric contraction. Then there is, you see, in alpha 1 we have further divided into alpha 1A and alpha 1BD. Where I was talking about alpha 1A, which is present in prostatic urethra and eyes, alpha 1BD, it is present in blood vessels, and when stimulated it causes vasoconstriction. Then alpha 2 receptors, these are presynaptic and they regulate the release of the drugs. So when they are stimulated, actually there is decrease in the release of these sympathetic neurotransmitters, that is norepinephrine, epinephrine. So understanding that presynaptic means actually it will be acting like a sympatholytic because there will be decrease in the release of these drugs. Okay, so when in brainstem they are stimulated, they cause a decrease in the sympathetic outflow. So that is important, that we will see how they are acting, right? Then beta receptors, we have beta 1, beta 2 and beta 3. Beta 1 receptors are present on heart and JG cells. In heart, when stimulated, they cause increase in the heart rate, increase in the contractility of the heart. In JG cells, they cause release of the renin. Beta 2 receptors mostly present on the smooth muscles throughout the body. In bronchus, they will cause the bronchodilation. In GIT, they decrease GI motility, so there also they inhibit the contraction, right? Bladder, they inhibit the contraction of the detrusor muscle. Uterus, again they inhibit the contraction, right? And liver also they are present, so they are responsible for regulation of metabolism also. So they cause glycogenolysis, increasing the glucose concentration in the blood. They are present in blood vessels as well, especially in skeletal muscles. See, in most of the blood vessels, it is alpha 1 receptors, okay, alpha 1 receptors where they cause the vasoconstriction. Except these, the ones which are present on the blood vessels of skeletal muscles, they cause vasodilation. Okay, then we have the beta 3 receptors which cause lipolysis. No other function of beta 3 receptors has been found. However, recently we have found that these beta 3 receptors are also present on a urinary bladder. So stimulation of that receptors, just like that of the beta 2 receptors, causes the relaxation of the detrusor muscle. Now, one thing you remember here, that 2 catecholamines which are released in the body, actually 3 are there in the body, that is epinephrine, norepinephrine and dopamine. Okay, now epinephrine acts equally on all the receptors, that is alpha and beta, but in low doses, if we talk about its action on the blood vessels, its beta 2 activity is more compared to alpha activity, that alpha which we talked, no, alpha 1 receptor which is present on blood vessels. Epinephrine acts on all the receptors, but in low doses its beta activity, beta 2 activity on skeletal muscles in the blood vessels, it is more. Okay, that is one thing. Norepinephrine, remember, it has no beta 2 activity. All other receptors it acts, no beta 2 activity. So it won't act on the these smooth muscles of the various organs, and it won't act on the beta 2 receptors which are present on the blood vessels of the skeletal muscles. So with this, directly we will move on to the classification of the sympathomimetics. Okay. So here we have the classification, that is directly acting, indirectly acting, and the mixed acting drugs. Okay. So directly acting drugs means that these drugs are directly going, they will directly go and bind to the receptors. So that's why they are known as directly acting. Indirectly acting, how they will do, say suppose this is the neuron, say suppose this is the neuron, and these indirectly acting, what will happen, that they will inhibit the uptake of the catecholamines which are released in the body, that is norepinephrine which is released from the neurons. See, after release, this most of this norepinephrine which is released is taken back into the neuron terminal and it enters back into the synaptic vesicle. So there are drugs which inhibit this reuptake, so they are known as reuptake inhibitors, and there are drugs which act by displacement, that is they will cause the displacement of this norepinephrine which is present inside the synaptic vesicle, so that it can be released more. So these are indirectly acting. That means they themselves are not stimulating the receptors. Instead, the norepinephrine which is released, it is maintaining that levels, it is increasing that levels in the junction in the synapse. Okay, so that is why you see it is inhibiting. How it is acting? Basically it is inhibiting the uptake, and it is causing action by displacement, where it is causing more release of norepinephrine and dopamine from the synaptic vesicles. Then there are others which we are not going to discuss in this video, that inhibit the metabolic enzymes, because this norepinephrine and epinephrine which are released, they are also metabolized. Okay, they metabolized, and the main metabolic end product is VMA. Okay, and the metabolic enzymes are MAO and COMT, that is monoamine oxidase and CO methyl transferase. Okay, so these are the drugs which can act by inhibiting this metabolic enzymes. Then there are mixed acting drugs which act by both, that is they can directly stimulate the receptors also, and they can also increase the release of norepinephrine, maintaining its concentration. So let us see one by one what are the drugs in this, and then we will talk about each drug individually. So in directly acting drugs, we have catecholamines and non-catecholamines. So directly acting is further divided into catecholamines and non-catecholamines, and catecholamines are further divided into endogenous and exogenous. Endogenous means which are released in the body. So these include dopamine, adrenaline and noradrenaline. Okay, so we know that the sympathetic system causes release of these endogenous catecholamines. So dopamine is the one from which this noradrenaline, adrenaline are synthesized. Exogenous catecholamines include dobutamine, dopexamine, phenol dopam. So all like where the word dopa is there, right? So here you see dopa, dopa, dopa. So dobutamine, dopexamine, phenol dopam, and there is isoprenaline. So that is catecholamines, endogenous and non-endogenous catecholamines. Then we have the directly acting non-catecholamines. So again multiple drugs are there. We will better understand it when we talk about whether they are stimulating specific receptors or not. So some examples of these non-catecholamines include clonidine, xylometazoline, phenylephrine, salbutamol, methoxamine. Okay, it is difficult to remember like that. I better remember it based on the receptors which they are stimulating. Okay, so that non-catecholamines are there. Okay, so these two we will club together and we will see that which receptors they are acting, right? Then next we have the indirectly acting, which include the reuptake inhibitors, in which we have cocaine and tricyclic antidepressants. Then there is action by displacement, in which we have amphetamines, methylphenidate and modafinil. Okay, so that is about the indirectly acting. Moving on to mixed acting drugs. In mixed acting drugs, we have ephedrine, pseudoephedrine and mephentermine. Okay, so some examples of these drugs you should remember, especially the ones which I was talking about in the directly acting, the catecholamines. Some examples you should remember, but you should better remember them as that which of them is the agonist of which receptor. Okay, so that we are going to talk about now one by one, that what is the action of these drugs. So here we have that which is the agonist, which are non-selective and selective agonists, and we have the alpha agonist and beta agonist. So in alpha 1 agonist, we have nafazoline, oxymetazoline, xylometazoline, phenylephrine, methoxamine, mephentermine and midodrine. Okay, so these you remember, nafazoline, oxymetazoline, xylometazoline are together. Okay, so their names are similar, right? Then we have phenylephrine. Okay, then we have three drugs with M: methoxamine, mephentermine and midodrine. Okay, then we have alpha 2 agonists which include clonidine, apraclonidine, brimonidine, dexmedetomidine, okay, and lofexidine. So all these dene are alpha 2 agonists. Then we have guanfacine and guanabans, which are not used now, but yes, they are the prototype of alpha 2 agonists. We also have one other drug which is not dene in this, methyl dopa, right? So these are alpha 2 agonists. Then coming to beta agonist, we have non-selective beta agonist drug which is isoprenaline. Isoprenaline stimulates only beta receptors and not alpha receptors, all beta receptors, but it stimulates. So that is why non-selective beta agonist. Then we have beta 1 agonist, that is dobutamine. Okay, dobutamine. Beta 2 agonist, all of them end with all, or not all, most of them end with all. We have salbutamol, salmeterol, formoterol. Okay, then we have terbutaline. Then two other drugs which we will see, their action is also different. Actually these all act like similar action, but two other drugs are there, ritodrine and isoxaprine, which act in a different manner. They act on different organ. Okay, so that is there. Then beta 3 we have mirabegron. Okay, remember that effect of these drugs depend on selectivity and presence of receptors. So if a drug is acting on beta receptors, suppose beta 2 receptors it is acting, so action on beta 1 is less, and beta 1 is present in heart, so its action on heart will be less, its action on other muscles will be more. So that's why you should know that where are these receptors and what is its action. So let us go into each of these drugs one by one. First is directly acting catecholamines, in which we have the endogenous catecholamines. So these are basically the endogenous catecholamines. Okay, so first we are discussing that, and these endogenous catecholamines are not given orally, please remember, because these are inactivated in intestinal mucosa and liver because of the presence of enzymes MAO and COMT. So they are never given orally. So in endogenous catecholamines we have three drugs: adrenaline, noradrenaline, or also known as norepinephrine, and dopamine. Okay, now I told you before, adrenaline has both alpha and beta action. In low doses, beta action is more, beta 2 action on the blood vessels, alpha action on the blood vessels is less. Okay, so this adrenaline, since it has both alpha and beta action, it is the drug of choice for anaphylactic shock. Remember this, it is basically used in all kind of allergies, anaphylactic shock. So apart from anaphylactic shock, urticaria, angioedema also occurs because of this anaphylactic shock. There is too much edema, and especially laryngeal edema, if it occurs, there will be blockage of respiration and the person can die. So this adrenaline, when given in anaphylactic shock, is life-saving. And the preferred route for this is intramuscular route, which is used in the dose of 0.5 mg of 1:1000 solution. Okay, if it is given IV, then we have to dilute it further, remember it, because then it can be dangerous. So in cardiac arrest, it is used by IV route. Okay, anaphylactic shock by intramuscular route, cardiac arrest by IV route, right? Then adrenaline is also used to increase the duration of action of local anesthetics. So in a very diluted form, along with the local anesthetics it is given, so it causes vasoconstriction, and if there is vasoconstriction, then local anesthetics will not be able to enter into the systemic circulation. They will be present locally only. So because of this, their concentration locally is going to increase, and second thing is that because they are not going into the systemic circulation, their toxicity will be less. Okay, so they increase the duration of action of local anesthetics and decrease their systemic toxicity. Then they also decrease the local bleeding. So for example, some procedure is being done, okay, say suppose endoscopy is being done and there is local bleeding during that time, so this adrenaline can be given locally. Second, epistaxis, so swabs with very diluted adrenaline can be kept in the nose to decrease the bleeding. So local bleeding also is decreased by adrenaline. Okay, and what is its effect on heart and blood vessels? See, this adrenaline, noradrenaline, isoprenalin, we will see together combined their effect on heart and blood vessels, and hence its effect on blood pressure. Okay, just we will see here briefly and then we will look at them together. See, I told you adrenaline has both alpha and beta action. So due to its action on beta 1 receptors, it causes increase in the heart rate and stroke volume, and hence there will be increase in the cardiac output. Our physiology, we know that cardiac output is the determinant of systolic blood pressure. So when cardiac output increases, systolic blood pressure is going to increase. On the other hand, I told you that in low doses, its beta 2 action is more. Okay, so there is vasodilation. Suppose dose is bit higher, there will be alpha 1 action also. So there is both vasoconstriction and vasodilation which cancel out each other. Hence, there is no change in total peripheral resistance. Okay, low doses, there will be decrease in total peripheral resistance because of some vasodilation. So here we are talking that not much change in total peripheral resistance. And again, from our physiology, we know that determinant of diastolic blood pressure is total peripheral resistance. So if there is no change in total peripheral resistance, there will not be any change in the diastolic blood pressure. Okay, so that is adrenaline. This adrenaline is contraindicated with beta blockers. Why? Because you see its effect on vasodilation will not be there, and there might be too much increase in the vasoconstriction. That will cause too much increase in the blood pressure and hence can lead to cerebral hemorrhage. Cerebral hemorrhage. Okay. Now coming to the next drug, that is noradrenaline. I told you before that noradrenaline doesn't has any beta 2 action. Okay, it has beta 1 action. So beta 1 action is going to increase the heart rate, that is going to increase the cardiac output, and that is going to increase the systolic blood pressure. Cardiac output determinant of systolic blood pressure. And because of its action on alpha 1 receptors, it leads to extreme vasoconstriction and hence increase in the diastolic blood pressure. Okay. So this is the difference compared to that of the adrenaline. Adrenaline, we said that hardly any change in the diastolic blood pressure. Noradrenaline, you see vasopressor action is too much because there is no beta 2 action, and in fact noradrenaline can be given in septic shock where we need the pressor action. Remember that in other types of shock, you see my video on shock, how that compensatory changes occur in shock, so you will understand that better. Actually, in other types of shock, there is extreme vasoconstriction because sympathetic system is too high. So already there is vasoconstriction. So if we give norepinephrine in that, hardly there will be any effect because already sympathetic system is sympathetic activity is high, right? So hardly there will be any effect. It will not be of any use. But in types of shock where this vasoconstriction is not there, for example in septic shock, in that case this noradrenaline can be used. Can it be used in anaphylactic shock, which we said that adrenaline is used? No, it cannot be used in anaphylactic shock. Why? Because there is no beta 2 action. So we have seen that beta 2 receptors are present in the muscles and bronchus also. So this beta 2 stimulation causes bronchodilation, which is very important for treatment in anaphylactic shock, right? Here no beta 2 action. Also, there is another reason. Adrenaline actually has some antihistaminic action also. It causes decrease in the release of the histamine. So that is also beneficial in case of anaphylactic shock. Okay. So noradrenaline can be used in septic shock for its pressor action, not used in allergy, right? Then moving on to third drug, that is the dopamine. Dopamine has three different actions depending on the dose. Okay, so the dose can be low dose, moderate dose, or high dose. Okay, low dose, that is 1 to 2 microgram per kg per minute, right? Moderate dose, that is 2 to 10 microgram per kg per minute, and high dose greater than 10 microgram per kg per minute. When it is given in low dose, its main action is D1 receptors only, where it causes renal vasodilation. In moderate dose, it stimulates beta 1 receptors, and we said beta 1 receptors are present in heart, right? High dose, it also stimulates alpha 1 receptors. So this dopamine is drug of choice for cardiogenic shock. Cardiogenic shock means heart pumping ability is less with oligouric renal failure. Why? Because you see, it is causing renal vasodilation. So that means it tends to maintain the renal blood flow and hence maintains the GFR. So that is why it is used for cardiogenic shock associated with renal failure. Okay. And which is the dose in which it will be used? It will be used in moderate to high dose, right? Why? Because low dose, it is only stimulating D1. We want its action on beta 1 receptors as well. Okay, so we start with moderate dose, and depending on the response, we move on to the higher dose. Then moving on to exogenous catecholamines. After this, we will see that how different receptors are being stimulated. So receptor based classification we will see after this. So exogenous catecholamines, we have dobutamine, dopexamine, phenaldopam and isopranaline. Dobutamine is beta 1 agonist. Okay, so we will discuss it again in beta 1 agonist when we are talking about that. So dobutamine is beta 1 agonist, and it is used for short-term treatment of cardiac decompensation which follows myocardial infarction or cardiac surgery. This dobutamine acts for very small time, 1 to 2 minutes. So, since it is a beta 1 agonist, very short-term treatment of cardiac decompensation. Cardiac decompensation means that despite the compensatory mechanisms, the heart is not able to pump properly. So, for very short time, this dobutamine can be used for stimulation of the heart after MI and after cardiac surgery. Then we have dopexamine, which is beta 2 plus D1 agonist. Okay, phenaldopam, important that it is used for hypertensive emergencies. Phenaldopam. Okay, since it is a D1 agonist and it is a rapidly acting vasodilator. Okay, important. It's a D1 agonist which acts very rapidly. Actually, in minutes it starts acting. So it is used for hypertensive emergencies. What is its characteristic? Rapidly acting vasodilator. Then isopranaline, it is a non-selective beta agonist. I told you before, it acts on all three types of beta receptors, and it is used for AV block and bradycardia in patients who have cardiac pacemaker. See, in our video on parasympatholytics, that is antimuscarinics, we read that atropine is the drug of choice for AV block. Yes, but in patients who have cardiac pacemaker, there is no use of giving atropine because that neural connection is not there. Okay, so vagal supply is blocked by atropine, right? Now it is not there. We want something to directly stimulate the heart. So there will be receptors present. So this isopranaline directly acts on beta 1 receptors and cause the stimulation of the heart. Blocking of the neural supply doesn't mean anything in a pacemaker condition because there is no neural supply to the heart, right? So with in a patient with cardiac pacemaker, if there is AV block, then isopranaline is the drug of choice, right? So moving on to now the selective agonist, and we will discuss each and every drug. So first is alpha 1 agonist. In alpha 1 agonist, I told you before, we have all the zolines, that is napazoline, oxymetazoline, xylometazoline. Alpha 1 receptor is present on blood vessels, very important. Its action which we use clinically is mainly because of its action on blood vessels. Okay, nafazoline, oxymetazoline, xylometazoline, they cause vasoconstriction and hence they are used as nasal decongestants. Then phenylephrine. Phenylephrine is also used as nasal decongestant. Okay, so if you have some medicines in your home that in cold, whatever syrup is given, that is having this phenylephrine. Okay, then inhalers, if you see, which are used for decongestion of the nose, that is having this nafazoline, oxymetazoline. However, remember one thing, that we cannot use these drugs for long term. Why? Because there are chances of atrophy of nasal mucosa. In fact, after congestion is also there, very common rebound phenomena is there after congestion, and if it is used for long term, it causes atrophy of nasal mucosa, that is known as rhinitis medicamentosa. Rhinitis medicamentosa. Okay, so it should not be used for long term, that is one thing. So second thing is, since it is alpha 1 agonist and it is causing vasoconstriction, so very carefully we have to use in hypertensives. Okay, better to avoid only in hypertensives. Phenylephrine, I told you, yes, that it is used as nasal decongestant and it is also a mydriatic. Okay, so it causes the dilation of the pupil and that's why it is used for fundus examination in adults. Okay, so that dilation of pupil will there. So when we visualize the fundus, we can visualize the whole area. For fundus examination, we need mydriatics. Okay. Next is midodrine. Midodrine is the drug which is used for treatment of orthostatic hypotension. Okay, it's a prodrug in the body. It is converted into its active form. It is used for the treatment of orthostatic hypotension and side effect is supine hypertension. So it should be avoided at night. Okay. Then other drug we have methoxamine and mephentermine used for hypotension. Actually, the hypertension which is caused due to decrease in the blood volume, preferably we don't give alpha agonist because it is better to use volume expanders. We need to increase the blood volume, right? But hypotension can occur due to other reasons also, like orthostatic hypotension I told you. So midodrine is used. Then mephentermine is used to prevent hypotension which accompanies spinal anesthesia. In a spinal anesthesia, there is block of this sympathetic outflow. So to prevent that hypotension, mephentermine is given. And mephentermine we saw, here we are studying in alpha 1 agonist. Mephentermine we saw in mixed acting drugs. Okay, so it has both direct and indirect action. Moving on to alpha 2 agonist. Alpha 2 agonist, we have all those dene, okay, clonidine, apraclonidine, brimonidine, okay. So let us see what are these. Clonidine decreases sympathetic outflow from CNS, okay, and that is why it can be used in hypertension. But apart from use in hypertension, there are many other uses of clonidine which include diarrhea in diabetics, okay. In diabetics, there is autonomic neuropathy and hence there will be increase in the GI motility. So for that we need to block the sympathetic action. So we have diarrhea in diabetics, okay. Then we have treatment of withdrawal symptoms in alcoholics, nicotinics and opioid addicts. So what happens, all the withdrawal symptoms have some sympathetic activity features, so that can be blocked with clonidine. Then tics in Tourette syndrome and also for the treatment of ADHD, clonidine can be used. So we will see the preferred drug is something else. Okay, so these are the actions of clonidine. It can also be used for prophylaxis of migraine. Okay, so these are some other actions apart from its use in hypertension. And we have to remember that when clonidine is given intravenously, transiently it may increase blood pressure. So we have to use with caution. Why it can cause increase in blood pressure? Because there are some alpha 2 receptors which are also present in blood vessels. So if those are stimulated, then there will be increase in blood pressure. Then other alpha 2 agonists, methyl dopa, again treatment for hypertension. Apraclonidine and brimonidine, it is used as adjunct therapy for glaucoma. Actually, they are for topical use only. Okay, apraclonidine and brimonidine we put in eye for the adjunct treatment of glaucoma. I told you before also, glaucoma we will have a separate video. We will talk about the mechanism of various drugs. Okay. Apraclonidine does not cross blood-brain barrier, while brimonidine crosses blood-brain barrier. So apraclonidine is preferred. Then we have dexmedetomidine, okay, and it can be used as pre-anesthetic medication, right? Next is tizanidine, which is a muscle relaxant for treatment of spasticity in cerebral and spinal disorders. Okay, tizanidine for muscle spasticity. Then guanfacine and guanabenzine, I told you they are not used. Okay. Then we have beta 1 agonist. Beta 1 receptors are present in heart and JG cells. So here beta 1 agonists are mainly used for its effect on heart. We have dobutamine. Dobutamine, I told you that it is used for short-term treatment of cardiac decompensation, post-heart surgery or MI. And why is the reason? Because it has more prominent inotropic action than chronotropic. See, when heart rate increases, then oxygen demand by the heart increases too much. So because the dobutamine has more inotropic effect compared to that of the chronotropic, it can be used for short-term treatment of cardiac decompensation. Then we have a new drug, pranilterol. Pranilterol, which is approved for reversal of beta blockade. So if beta blockers are used and there is toxicity, so this drug, pranilterol, can be given. Next we have beta 2 agonist. I told you all drugs ending with all: salbutamol, albuterol, salmeterol, formoterol and terbutaline. So these are all beta 2 agonists. And we have two other drugs, that is ritodrine and isoxsuprine. Now this salbutamol, albuterol and terbutaline are short acting beta 2 agonists and they work for 4 to 6 hours. Okay, so these drugs cause bronchodilation. Beta 2 receptors are present in bronchus, so they cause bronchodilation and are used in bronchial asthma. Main side effects of these are tremors. Okay, tremors. Then some beta 1 activity is also there. That's why it leads to palpitation, restlessness and anxiety. Restlessness, anxiety, because of this palpitation only it occurs. Okay. So these are the common side effects which occur with beta 2 agonists. However, tolerance develops. So when they are used over time, tolerance for these side effects develops. Then we have long acting beta 2 agonists, salmeterol and formoterol. Among this, salmeterol starts with S. It is slow to start. Okay, so that is why it is not to be used to treat acute attacks. Very important, because it is taking time to start. So we should not use it for treatment of acute attacks. That is salmeterol. Then we have formoterol. Both these salmeterol and formoterol are long acting. Their action lasts for like 12 hours. So that is why they can be used for nocturnal asthma. Okay, I told you salbutamol, albuterol, terbutaline, they are short acting and their action lasts for 4 to 6 hours. Salmeterol, formoterol, long acting, action lasts for 12 hours. Okay, then we have ritodrine and isoxsuprine, which I told you they act on some other organs. So they act on uterus and they can be used as tocolytics. Okay, tocolytics is, that is relaxation of the uterus. So they can be used for preterm labor where they will cause the relaxation of uterus. But still no efficacy has been found. In fact, there is no effect on perinatal mortality. So obviously if there is no effect on perinatal mortality, they are hardly used. Okay. Then we have beta 3 agonists. I told you that newer drugs are coming up which are beta 3 agonists, since this beta 3 receptors has been found in urinary bladder. So this beta 3 agonist, mirabegron, acts on urinary bladder and causes its relaxation. So it is used for treatment of overactive bladder. Then we have non-selective beta agonist, isoprenaline. This isoprenaline, we have already seen that it is used for patients of AV block and bradycardia in patients with cardiac pacemaker, right? So till now we have discussed about selective and non-selective agonist. Moving on to indirectly acting drugs. Okay, so indirectly acting drugs, we have amphetamines, methylphenidate, dexmethylphenidate and modafinil. Amphetamines have a high abuse potential, so they are hardly used. Okay, that we have to remember. Though they have been used before for ADHD, narcolepsy, and also for obesity. Obesity because they decrease the hunger. So actually they act on the level of hypothalamus, the lateral hypothalamus, and they decrease the hunger. Okay. However, remember that amphetamines have a high abuse potential, so they are hardly used for these drugs. In fact, methylphenidate is the drug which is preferred for ADHD. Okay. Then modafinil is recently approved for use in narcolepsy, then shift workers, and as an adjunct treatment in obstructive sleep apnea. Okay, so these are like a little bit different what we have seen the actions of sympathomimetics. But one thing we should remember that these drugs stimulate the sympathetic receptors present in the brain also. And in the video on sleep, mechanism of sleep, we have seen that how norepinephrine is an important neurotransmitter for maintaining wakefulness. So that's why its action on narcolepsy, because narcolepsy, what happens, there is daytime sleepiness. So that's why it can be used for narcolepsy. Second thing is that ADHD. ADHD, how it can be used? See, it is maintaining wakefulness and it is increasing the concentration also. And in ADHD, main problem is in concentration. Okay, so that is why these indirectly acting drugs can be used for ADHD, where they basically promote the release of norepinephrine. So that is why they can be used for narcolepsy and ADHD. They can be used for obesity because these receptors, they are also present on lateral hypothalamus. In fact, for obesity, actually there are serotonergic drugs also. So they act by acting on the satiety center, and amphetamines act by acting on the lateral hypothalamus, the appetite center. So amphetamines inhibit the lateral hypothalamus and causes anorexia. Fine. Then we have mixed acting drugs, pseudoephedrine and ephedrine. There is another drug, mephentermine, which we have already seen that it is used to prevent hypotensive episodes during spinal anesthesia. Okay, so here we have pseudoephedrine and ephedrine. Ephedrine is the vasopressor of choice in pregnancy because it does not interfere with placental circulation. Pseudoephedrine, that can also be used as nasal decongestant. Now, before we finish, very important, we will see the difference between the norepinephrine, epinephrine and isoprenaline action on heart and on the blood vessels, that is finally its effect on blood pressure. So here we have three columns. One has norepinephrine, other has epinephrine and isoprenaline. So to understand, you remember that norepinephrine major action is on alpha and beta 1 receptor. Beta 2 action is not there, norepinephrine. Epinephrine on all receptors. In low doses, preferably beta 2 more than alpha 1. So in vessels, preferably beta 2. Isoprenaline, only beta, no alpha. Okay. So because of alpha action, see, norepinephrine is going to cause vasoconstriction, and because of beta 1 action, it is going to cause effect on the heart. That is going to increase the cardiac output, right? So that is going to increase the systolic blood pressure. Now, you see that there is increase in systolic blood pressure. So you see this is the baseline systolic and diastolic blood pressure, and here norepinephrine is given. So there is increase in the systolic blood pressure and there is increase in the diastolic blood pressure also. Why? Because it is causing vasoconstriction. So mean arterial pressure is increasing. Now what happens? Because of increase in the mean arterial pressure, baroreflex works and this causes decrease in the heart rate. Okay, so we are getting decreased heart rate due to reflex decrease in sympathetic activity, right? So decreased heart rate with norepinephrine. Epinephrine, there is alpha action which will cause vasoconstriction, but beta 2 action is more. Okay, remember. So we have diastolic blood pressure which is decreased. Why? Beta 2 action is more in low doses. So there will be vasodilation. Vasodilation causes decrease in the peripheral vascular resistance. So there is decrease in TPR. Okay. Beta action, Yes, there is increase in the cardiac output, both activities there. Increase in the cardiac output, there is increase in systolic blood pressure. So that's what we are seeing, increase in systolic blood pressure and decrease in diastolic blood pressure. But mean arterial pressure is not increased that much, right? So that is why baroreflex action will not be that much. So we have increase in heart rate due to its beta 1 action. See, beta 1 action is going to increase heart rate, baroreflex will tend to decrease the heart rate, but since mean arterial pressure has not changed that much, ultimately its beta 1 action will be more prominent and there will be little bit increase in the heart rate. Okay. Moving on to isoprenaline. Isoprenaline has only beta action. So we have vasodilation, not vasoconstriction because no alpha action. Heart rate increases, right? Because you see diastolic blood pressure is decreasing. Because you see, because of so much fall in the TPR, total peripheral resistance, diastolic blood pressure is decreasing. Systolic blood pressure, even though it is increasing, you see mean arterial pressure, it is going to decrease. Okay. So because of its beta 1 action, we have much more increase in the heart rate. Okay, I can write it as much more increase in the heart rate. Simple. Norepinephrine, vasoconstriction occurs and heart action increases the cardiac output. So we have increase in the mean arterial pressure, reflex decrease in the heart rate. Epinephrine, we have not much change in mean arterial pressure. Due to its beta 1 action, we have some increase in the heart rate. Isoprenaline, no vasoconstriction, total peripheral resistance decreases too much. So, mean arterial pressure decreases and we have increased heart rate due to its beta 1 action. So that was all about sympathomimetics. I hope that the video made some sense to you regarding sympathomimetics and action of each and every drug. Thanks for watching the video. If you liked it, do press the like button, share the video with others and do subscribe to the channel Physiology Open.